be going through cases with the CBCT and ITX today. So we're not going to have a lecture to start because we have, I think, 9 or 10 cases to get through. So if you want to go to the next slide here, Hussein. So with us from ITX, we have Dr. Hussein. He's been with us at each of the other grand rounds. He works with ITX. He's one of their prosthodontists here, who does some of the treatment planning there. So he took all the cases that were submitted there, reformatted them, planned the implants, and we'll be going through them one by one. So thank you for being with us here,
Thank you for having
Dr.
me, Dr.
Hussein.
Resnik.
And let's jump into the interactive treatment planning here. So you want to start us off with the first case?
Yes, sir, right away. So first case is for Dr. Neha Gupta. Dr. Gupta, would you mind unmuting yourself and presenting your case to Dr. Resnik?
Yes. Hi, Dr. Resnik. So my
Hi, Dr. Gupta.
patient, yes, I'm sorry, I'm just rushing through. So I'm at the airport right now.
Yes.
Yeah. So my patient is 84-year-old female, medical history, just a thyroid disease, and she's taking medication for that, allergic to sulfa drugs. She presented with grade 4 mobility, number 7 and 8, and is interested in replacing them with implants. She's currently actually using her ortho retainers to hold them in place.
Okay. Okay, perfect. So with the thyroid disease, the only thing we're worried about there is the bone metabolism. So it's good that she's on medication for that. That would be really the only thing to worry about with the thyroid disease, but it's good that it's being controlled there. So you want to go through the cross sections there, Hussein, for 7 and 8?
Right away, sir. So that's the first side, the side of number 7. I'm going to switch on the segmentation for a second. So here you go, Dr. Resnick. We've got a periapical pathology related to the side of number 7. The labial concavity is a little bit accentuated. As we scroll forward towards the side of number 8, sir, we're noticing over here a resorbed root and an accentuated nasopalatine canal over here, sir.
Can you pull up a bigger view of number 8 there, Hussein?
Absolutely, sir. Here you go.
Here, are you sharing the screen here, Hussein? I'm not getting any change here.
Sorry, Doc. Yeah,
Okay,
here
there
we go.
it is. Okay. So go through 7, then go through 8 as well. So
Here we
this
go.
is 7 here. So there's the periapical radiolucency you see there surrounding the apex there. And then Doc, both these teeth are mobile. Do they both have resorbed roots?
Yes.
Okay. Yeah, because the root on number 8 looks very, very
Hmm.
shallow there. So, and you said they're class 3, 4 mobility?
Yes.
Okay. Okay. Perfect. So that's number 8 there. And the patient's 84 years old, correct?
84-year-old.
Okay.
Yeah.
Okay. Perfect. So go back to 7, and do you want to put your planned implants in there? You're
So
saying,
I did plan an implant, Dr. Resnick, over here. The side of number 7 is a 3.0 by 13 millimeter long implant. As I rotate around this one, Dr. Resnick, I'm clear away from the laminator of the adjacent tooth. I'm engaging beyond the extraction socket and the periapical pathology of this one, exactly 7.7 millimeters of native bone, but we've got minimum bone thickness over here to the labial concavity at the middle third of my fixture, sir.
okay. Yeah. So just looking at number 7 here. So it's good that it's a resorb root. So whenever we're doing immediate implants, we want to engage at least 2 to 4 millimeters of apical bone. So that's not an issue for this case to obtain primary stability. Concerns with just this site here is one going to be the periapical radiolucency. When you kind of degranulate that, you're more than likely going to be losing that buccal plate, or it will be very, very thin there. Secondly, where that concavity is, it's very difficult to try to graft that area when placing the implant. So it's kind of like a catcher's mitt pretty high up from where the tooth is there. So it's going to be difficult to determine if kind of you've fenestrated it or you have a perforation when placing the implant there. So those kind of 2 reasons are going to be very difficult to get an immediate implant in at the time of taking out number 7. So with number 7, the more predictable way would be to get the tooth out, degranulate the infection there, and just socket graft it. If you're able to maintain the buccal plate, you can treat it kind of like a GBR with the catcher's mitt and graft that mid facial kind of like halfway down the implant there and try to bulk that out because you're going to need more bone on that for the implant, even if you were going to do it immediate there. So I would probably take out that tooth, lay a flap, and then graft it like a GBR. It will be a very predictable GBR in that segment because it's a catcher's mitt. So it will just hold the bone graft material in there. Do you want to go to number 8 there, Hussein?
Absolutely, sir. So for number 8, Dr. Resnick, what I had in mind is a 35 by 13 millimeter long implant. But as you notice, sir, I'm so close to the nasopalatal canal to the palatal aspect, especially at the middle third, and I'm nearly fenestrating the labial platal bone over here to the facial aspect, Dr. Resnick.
Yes, so that's going to be even more difficult at number 8 there. Not only with the bone on the lingual with the canal in that space, but the concavity there. So the most predictable treatment for this patient is going to be to take out 7 and 8. When you're doing it, lay a flap down to the apex of where those implants are, and you'll do a GBR across that segment. You'll be able to grow the bone beautifully, and it'll make coming back in, 4, 6 months just very easy and manageable for that there. It's just going to be too difficult to try to grow bone when placing the implant there because you're going to have fenestrations, and it's going to be very difficult to get to there. So for this case, I would do delayed placement, take the teeth out, do a GBR where that concavity is at 7 and 8, and then come back in 4, 6 months, and you'll be able to get two good implants in there with abundant bone there.
Perfect. Doc, since we are not we are doing a delayed placement, so for tissue contouring in the aesthetic area, do you recommend doing Essex with Pontex?
Yes. So, um, your different treatment options on what you can do for temporaries. One is going to be an Essex. Second is going to be a flipper. Probably the best is going to be a smile transition,
Okay.
or yeah, smile transition from Gladwell. Have you used one of them before?
No.
Okay, so it's pretty much an overlay Essex. It's going to be the most aesthetic because you don't have the clear Essex retainer around it there. It's also going to be the most durable, and it's not going to alter their vertical. So what they'll do is when it's hugging on the posterior teeth, they'll leave occlusal stops on the patient's actual teeth. So that's going to help the most. Now, in terms of building the papilla up, I would do that when you're going to place the implants and put them in the healing abutments and even put them in temporary restoration. So
Okay.
no matter what interim prosthesis you're going to have, you're going to lose the papilla between 7 and 8 there. So when you do place the implants, one, you can use custom healing abutments. So if you're going to do this case guided, ITX can actually make you custom healing abutments that will engage the implant based on your CBCT plan that will have contours of what the prosthetic would be. Second option is you can talk about immediate loading. So depending on how the bone graft goes and how good the bone quality is, you can put immediate restorations on them to develop the papilla. Or third, when you are restoring the case, you can put them in a provisional restoration and build out the papilla and emergence profile at that point.
All right, Doc.
Perfect. Any other questions on the case?
No, not so far.
Okay, good case and have a safe flight. Look,
Thank you. Thank you.
okay. Okay,
Perfect. Next case, Dr. Resnick, is for Dr. Haley. And Dr. Haley, would you mind unmuting yourself, presenting your patient? The remarkable medical history of this one, Dr. Resnick, is that the patient is hypertensive and does have diabetes mellitus, sir. So these are
okay.
the two remarks with this patient medical history. Go ahead, Dr. Haley.
Hi, Dr. Resnick. Thanks for taking a look at my case. The
Yes.
patient is in his mid-50s and his diabetes is pretty well controlled. He has a history of an all-on X that was placed in 2018, and so we're wanting to move forward with that on the lower arch at this time.
Okay, so he had all on X done on the maxilla back in 2018.
Correct.
Okay, and then now he has terminal dentition on the bottom and he's ready to kind of go through the same process.
Yes. 19 and 20 were extracted about 2 months ago, so those are still healing up and they were grafted.
Okay, okay, perfect. And on the maxilla, was the all on X immediate loaded or was it done delayed?
Um, I am not sure, but I know
Okay,
the doctor that placed it, and usually how he'll do it is he'll do an immediate load,
okay,
PMMA, and then
okay,
after healing, they'll switch it.
perfect. Okay. Perfect. So let's go through the cross sections here, Hussein. So we're accepting that these teeth are terminal here. You took out 19 and 20, grafted it already, and now the remaining teeth are ready to be extracted. So just go through the cross sections here and let's see what kind of the anatomy looks like surrounding the teeth and see if we see any kind of pathology or anything of significance there. Bruce. And the bone graft looks like it's filling in well there at 19 and 20. You said that was done about a month or two ago?
Yeah, so the CBCT is it's probably a month old,
Okay.
and so the graft has only been in there in about a month in the
Okay.
CBCT.
Okay. Okay, so they don't have much bone surrounding the teeth there. So just from looking at the cross section there, we can appreciate that there's no buccal plate surrounding any of these anterior teeth there, and very thin, if not minimal, lingual bone surrounding the teeth there. And then going through the posterior here, they do have a little bit of a lingual undercut here. So that's going to be something of significance trying to put implants in the posterior here. So your plan here is to do a all on X FP3 prosthesis, Doc?
Hopefully,
Okay.
yeah, that's the plan. I haven't done a whole lot of these, and the last one I did, somebody else placed the implants, but I had help with the prosthesis.
Okay. Perfect.
So,
Okay. And have you done many guided cases, Doc?
some guided and some with a universal guide,
Okay. Okay.
or just other implants.
Okay. So Dr. Hussein planned for 5 implants, A through E position here. So we'll look at his planning here, and then we'll kind of go through some alternative treatment options and look at it here. So first, from just looking at the pan view, number 24 there has some pathology surrounding it there. So that's something that we're going to try to deviate away from when placing it. Now, when we went through the cross section of those anterior teeth, we're not going to have any bone left with it there. So we're pretty much going to be doing um, alveoplasty to the apexes of these teeth just to gain the necessary width. In doing so, we'll also gain the necessary restorative space or prosthetic space for the restoration there. So we'll be doing alveoplasty by taking out the teeth pretty much there. So you want to go through these one by one here, Hussein?
Right away, sir. So that's our first implant, Dr. Resnick. I do have an implant at the side of E. That's a 4.3 by 11.5 millimeter long implant at the E position, sir. Good bone coverage to the facial and to the lingual aspect of this fixture. I'm perfectly clear, Dr. Resnick, away from where the mental framing and the anterior lobe anatomy is. And that's our first implant at the
Perfect.
E position. Next one, sir, is the side of number 22. For number 22, taking your notes into consideration, I pushed my implant as far deep to minimize the need for grafting. That's a 3.5, sir, by 11.5 millimeter long implant, adequate bone coverage to the facial and to the lingual aspect of this fixture. Using a straight MUA on this one, and on the previous implant at the E position, Dr. Resnick, I was using a 30 degrees MUA. Next one, sir, is the side of number 25. With this one, Dr. Resnick, I'm using right now a 3.5 by 11.5 millimeter long implant, planning it exactly apical or at the root anatomy or apical anatomy of that tooth. 3.5 by 11.5. Next is number 27, 3.5 by 11.5 as well. Over here, straight MUA on top of this one. And last but not least is the side of number 29, being a 4.3 by 13 millimeter long implant, still keeping a safety distance away from the anterior lobe anatomy and engaging good bone beyond the extraction sockets. The only reason why my fixtures are turning red, Dr. Resnick, is that they're a little bit less than 3 millimeters at the apical third, but at the platform levels, Doc, we've got more than 3 millimeters all around these fixtures, sir.
Perfect. Perfect. Great. So the implants are positioned great there, Dr. Hussein. What I like is you have great length and size of the implants. You have 5 greatly positioned implants there. Now, if we're looking at this view right here, what is also nice is going to be the emergence of them. So a lot of times when we're doing a lower FP3 and you take the teeth out, the ridge is going to resorb to the lingual there. So a lot of times your implants are going to be placed pretty lingual to the incisal edge. And in doing that, you're going to have a buccal cantilever where the teeth are. That's not only going to cantilever the teeth forward, but it's also going to create a lot more prosthetic width for the patient, which is going to be more challenging to get it adapted to with speech. So, based on this placement and kind of the emergence, if we're going to kind of make our wax up relatively close to where the incisal edge position is of these teeth, we're going to have a very nicely contoured prosthesis at the end of the day. So I think that's very good there. Now, let's go. So based on Dr. Hussein's plan here, we have 5 implants placed interforaminally there. So the benefit of placing them interforaminally there is we're taking out the mandibular flexure. risk of the prosthesis there. So an alternative treatment option would be to try to get implants distal to the foramina there, which were you considering trying to go distal to the foramina, Dr. Haley?
No, not
Okay. No. Okay. Good. So it makes things a lot more complicated there. So I think it was the bottom right there where he had a pretty significant lingual concavity there. So that's going to be one of the surgical risks. And then you're bringing in the mandibular flexure there. So if for some reason we had to go beyond the foramen, what we would do is we would section the prosthesis. So you would want to plan the implants, whether we're doing 6, 7 implants, plan them in a way where we're able to have a breaking spot somewhere in the anterior there. So you would split the implants into 3 and 3 or 4 and 3 there. But we're not going to do that in this case because you definitely don't need to there. In terms of the bone quality, you have great bone quality on each of these implants. You'll be engaging the cortical bone on the buccal and lingual of all of them there. So in terms of primary stability, you should have great primary stability with them. Uh, Probably your most challenging part is going to be to get these teeth out. It does look like they have pretty long roots, but fortunately, there's not really much bone around the roots, so you can do some plasty and then take the teeth out there. In terms of doing this case, you wanted to do an immediate load, Dr. Haley?
if we're able to. I mean, I
Yeah.
think that's kind of what the patient's expecting. I know when he
Yeah.
had his top done, he was under general anesthesia.
Okay.
So I that was one of the things I was concerned with, is just him being able to sit through it. Because when we took 2 teeth out, he was, you know, not loving sitting in the chair. He just is one of those patients that doesn't want to sit still. So it's definitely something
Yes.
I need to talk with him about and be like, look, we can do this, but it's not going to be a 30-minute procedure.
Yes, yeah. So that's why I asked the question how he did the upper, because what you'll find is patients have expectations. So, if their wife went through it and they did an immediate load, he's going to want to do an immediate load, or their neighbor did it, they want the teeth that day. So it's difficult to when the patient has their mindset. So for instance, he did his upper teeth and he never had to have an interim denture. So it's going to be difficult to put this patient in a lower interim denture if you're going to do it delayed. So that's going to be somewhat challenging with that. Um, I think getting these teeth out, there's probably no mobility to them, correct?
No.
Okay. So they are going to be, I think, somewhat challenging to get out there or somewhat time consuming from doing these cases and seeing them, especially at our hands-on cases. The majority of the time is spent on flapping these cases and taking the teeth out. Once the teeth are out, the guide's in place. It's very quick when you go through, universal guide, fully guided, however you want to do it there. It's just the flap and then getting the teeth out generally takes the majority of the time. If you were to do this immediate load, I think it would be a great stackable guide case. So what you would do is prior to taking any of the teeth out, you would lay a flap. So you do a full thickness flap surrounding all these teeth and expose the bone around them. And you'd go below the level of what you would be doing your alveoplasty. And then since these teeth are non-mobile, you would use the teeth to fixate the foundation guide. And the foundation guide is what's going to be used to kind of transfer the implant plan and the prosthetic plan of this CBCT to the patient's mouth. So you would fixate the foundation guide and then you would take the teeth out, do the alveoplasty, and then you would put on an implant guide there, do your implant drilling, and then once the implants are in, you would have a PMMA that already has the holes cut out that would go into the foundation guide. So that would be the probably smoothest and quickest way to do this case, but definitely you're gonna have a talk with him in terms of is he able to, tolerate a 2 hour procedure? With the drilling and all that there. You could talk about IV sedation or oral sedation if that's something that you do in your practice there, but to see if he's able to tolerate it.
Do you think it'd be better to try and take the teeth out and get him into like an immediate denture on the bottom first?
It yes and no. What's difficult with and you're aware lower dentures really don't work on the
Yeah.
majority of patients. So you're going to take them from having fixed teeth in the anterior and then give them a prosthesis that's going to be held in with fixed dent for, 2, 3 months.
Oh, he's
Um,
gonna
it,
hit it.
yeah, it would make it a lot easier to do the surgery by putting the implants in, but you're still going to have to lay a flap, which is going to take immense amount of time with it. Laying it flat for a fully dentures ridge can take some time. So yes and no. It will make your life easier, but I don't think he's going to be too happy being that he has something fixed on the top and then he's going to have something floating around on the bottom. So, but that is something to talk him through. Um, Now, cases that I do put patients in interim dentures will be if I'm significantly altering their vertical. So let's say this guy wore down all of his teeth to, nubs there or had some super eruption. Then I'm more inclined to put the patient in a denture to try to reestablish their vertical. But just from looking at the incisal wedge position of these teeth, it looks like he's probably at a pretty ideal position, if not minimal alteration. Correct?
Right.
Yeah. So it's going to be tough to get him to tolerate a lower immediate denture. So I do think it would be a good case for an immediate load. You're just going to have to see if he's able to tolerate it sitting in the chair for the amount of time needed.
Right. Thank you so much.
Yeah, great case, Doc. Great case.
Thank you.
And if you have any questions on the stackable guide, if you do get to that point, please reach out. Or Dr. Hussein's great with it. They send you kind of a whole kit there. So
Perfect. Thank you so much.
yes.
Thank
Okay,
you.
Dr. Hussein, let's go to the next one
So
here.
next case is for Dr. Schwalm. Doc, would you mind please unmuting your mic and presenting your case to Dr. Resnik? Dr. Resnik, there is no relevant medical history for this patient, so we should be in the clear, sir. Dr. Schwalm, are you here,
I'm
Doc?
here. I'm here. Can you
Perfect.
hear me? Okay.
Yes.
Yes, sir.
So it's a early 60s-year-old lady who has an upper denture. Her lower teeth are really busted up, and she would like a snap-on of some sort. She's been missing those lower posteriors a long time, lost a lot of bone. So she is aware that a lower conventional denture is just going to be terrible for her. I discussed with her um, both fixed and removable implant retained options. Her preference is an RP4 because of cost. Or RP5 because of cost. I would have preferred a 4, but got to do what
Yeah.
they want to.
Yes.
But my plan was to use Han implants, do probably, I don't know, I guess if I recall correctly, it's like 6 millimeters worth of bone reduction there in the anteriors, almost to the apex of those centrals, and kind of smooth it out. Put in 3 implants, let her heal in a transitional denture, and then convert her to the RP5.
Perfect. Yeah, so it's great. I like how you outlined all treatment options with her. So talked about a conventional denture, how they don't work on 95% of patients. Next option would be a RP5 with 2, 3 implants, RP4, 4, 5 implants, but it's going to be a lot more rigid, kind of function like a fixed prosthesis,
Right,
and then an FP3 there. So it's good how you
right,
outline it and kind of let her make the decision there. And what you'll find is your goal is to have 3 implants here, which would work great
yes,
because we can position them in a way where if that patient comes back in 2 years, let's say they hit the lottery and they want a fixed prosthesis, we can still use those 3 implants and just add additional implants and convert her to a fixed prosthesis, or if she wants something more retentive there. So
right.
I
Yeah,
think that's great.
I had planned on ACE
Perfect.
implants.
Perfect. And then what we can appreciate from this view that Hussein just had the line out there is you can see, as you mentioned, where the posterior ridges have resorbed significantly there. So kind of the level of the cortical bone in the posterior. So it's really sunken down there. So we'll go through the cross sections, but you'll be doing the alveoplasty, as you mentioned, to kind of the level of the posterior there to gain the
Hmm.
necessary space there. So and then if I recall, I think she has some tori on this one as well.
She does, and
Oh,
we'll be removing those
okay.
at the
Perfect.
time
Yeah.
of surgery.
Okay.
That way she's sore once.
Yeah. Yeah.
I was
No, absolutely. Yeah.
also planning on part of the reduction is just because of it's not huge, but there's kind of an hourglass uh,
Okay.
um,
Okay.
tendency in the anterior, so it'd
Yeah.
be the only way to get good restorative space as well as good bone for the implant platforms.
Yes. So Hussein, let's look at the 3D view, looking at it from the occlusal aspect, just to show the morphology of the ridge there. So let's start
Right,
there,
right away, sir. Here we go.
and then just turn that perfect right there, and then go from the occlusal there. So yeah, you can appreciate how significant that lingual undercut is there in the posterior. So that's a
Hmm.
pretty wicked lingual undercut there. You can see the tori there. And then you can also see the hourglass there where the teeth are, the ridge is narrow and then it starts widening out there. So by doing the alveoplasty, we're going to get more width for our implants there. So yeah, definitely removing the tori there if we're going to be doing any type of removable prosthesis there, which we can, will definitely help out here. So let's go through the cross section there, Hussein.
Yes, sir. Here we go. So I'm going to start at the right, sorry, left side. And so there were like a few multiple pathologies or like periapical pathologies related to the central incisors, the lateral incisors, Dr. Resnick.
Hmm.
And I'm going to show it to you right now, Doc. Yeah, can you see that periapical, very small periapical
Yes.
pathology over here as well. And as we scroll to number 25, just a little bit of a pathology. That's number 26. And here we go, sir. That's the right mental framing.
Okay. So in terms of that pathology, it's very minute. And as you mentioned, we're going to be doing plasty to the level of that. So when you take those teeth out there and you do the plasty to the level of the apexes, you should be able to get rid of all that soft tissue
Hmm.
and pathology surrounding it there. So I don't think that will be any issue there. And if so, we can even go down another millimeter or two of the plasty there. They have a ton of bone underneath those teeth for some good implants.
Okay.
So you want to start planning the implants here? You see?
Right away. Here we go. So I went a little bit wild with this one, Dr. Resnick. I went with the A, B, C, D, E position just
Okay.
to establish
Just to
that.
show, yeah,
Exactly, sir. And let me start by showing you the E position, Dr. Resnick. And for the E position, I do have a 4.3 by 11.5 millimeter long implant. Since that's the most distal implant to the left quadrant, we're perfectly clear. We have the mental framing, anterior loop anatomy. Then we've got the sorry, uh, yeah, we got then the 23 side, which is a 3.5 by 11.5 millimeter long implant. It does get a little bit thin over here at the
mm,
coronal aspect, but I could definitely sink my implant
you
just a
can,
tad
yeah,
deeper for better bone coverage, sir. Next, we got the C position, Dr. Resnick. And for the C position, I do have a 3.5 by 11.5 millimeter long implant over here. Good bone coverage all around, sir. Then we've got the B position, and we've got still do have a 3.5 by 11.5 over here. With this one, I could maybe push it just a tad to the lingual, give Dr. Schwalm over here thicker bone coverage to the facial aspect. And last but not least is the A position. With this one, I had to stick with a 3.5 by 11.5 just for better bone coverage to the coronal third of that fixture.
yeah.
Nevertheless, good bone all around, perfectly clear away from where the mental framing and the anterior loop anatomy is. What do you think, Doc?
Yeah, that looks perfect there. So let's go to this C position real quick, Hussein. So
Yes,
even though
sir.
we're only doing A, C, and E, they will always plan the B and D just to get them in the correct
Hmm.
distance to allow you to go back in the future and place an implant there. So
Hmm.
they'll always kind of plan the max number of implants in the front there. Now, in terms of the incisal edge position there, are these teeth at their appropriate level or have they super erupted upwards on you?
They're pretty close
Okay.
to where it is. She's comfortable at that vertical, so I if I change it, it won't be much.
Okay. So when you're making the interim denture, you're going to pretty much keep it at that incisal edge position or
That's the plan, and
okay.
if she functions well, try and keep her there for the long term
Perfect.
one. But
Okay.
if we need to adjust it, we have the opportunity to do so because we'll be doing a new one in a few months anyway.
Yes. Hussein, can you just measure from the platform of the implant to the incisal edge there?
Absolutely, sir. Here
So
we
what I'm going to
go.
just have him check here is just the restorative space. You have more than enough there. So you have 18. So that gives you some
Hmm.
leeway if you do need to shorten the incisal edge position there. Now, a lot of times what you'll see, and I think there's a case a little later here, is when somebody has an upper denture and they only have their lower anterior, you'll get super eruption there. So a lot of
Right.
times, what'll happen is those teeth will super erupt there. So we're doing a fair amount of alveoplasty to reestablish that incisal wedge position. So being that yours is relatively at the position that we want the final prosthesis, you'll be fine with the restorative space there. But that's something to
Okay,
always check when somebody comes in
right,
with their lower anterior teeth there. So,
right.
yeah, so that's
Okay.
great there. Now, in terms of doing this case, were you thinking of doing it guided?
I typically just do things freehand.
Okay. Yeah. So you could do it freehand. This would be a good case where, at minimum, you could do a reduction guide,
Yeah,
which would help remove the tori, and then also make sure you do enough plastic, because I think at that A position there, you were probably doing about six. Go to A there, Hussein, because that looked like a fair amount of plastic there, right? About six
yeah, it is.
millimeters. So,
Yeah, I had figured it was going to be 5 or 6 all the way across.
yeah. So,
Spot
I mean,
on,
if
Dr.
you're
Resnick.
fine, if you're fine eyeballing it, go for it. But a reduction guide would make this really easy because you'd get a very flat table going all the way across. But I think it's a great case there. ACE
Okay.
position, good bone quality. Yeah, I think it's great.
Okay, good. Thank you.
Any questions, concerns?
No, it just validates my thought process. I
Okay.
really appreciate that.
Awesome. Awesome. Well, good luck, Doc.
Thanks.
Okay, let's go to the next one here, Shane.
Dr. Janice Dioniso. And Doc, would you mind unmuting yourself, presenting your case, Dr. Resnick? One remarkable medical history about this one, sir, is that the patient is HIV positive or has been diagnosed back in 2017. So that's the remarkable history about this one, sir.
Yes, thank you. Thank you for taking this case. So I have a patient who's 70 years old. He has an upper and lower partial denture, a lot of soft tissue loss and bone loss. Would like to go with a fixed prosthesis and is really interested in having an immediate conversion.
Okay. Okay, so to take one step back in terms of the medical history, HIV, and I think he's taken Biktarvy there. So the only thing prior to doing treatment here is that's going to be a relative contraindication. So it's just something you'll have to get a medical consult for. You'll be fine, but just to make sure he's fit for surgery and healing there. So I would definitely get a medical consult, whether you're just taking one tooth out on him or doing an all on X case here. So. He has failing dentition. He's had a partial for some time and ready to convert to something fixed, Doc?
That's correct.
Okay, perfect. And the partial, is it broken down or is it are the teeth still kind of intact there? Because it looks like some of these teeth are broken down pretty good here.
Yeah, the teeth are pretty worn down.
Okay, pretty
And
worn down.
when he smiles, you can only see his lower teeth with the
Okay,
partials.
okay, okay. And you said he has some soft tissue loss, bone loss,
Yeah,
and
it's
all
got a
that.
lot of volume loss.
Okay, perfect. So let's go through the cross section. Let's start on the top here, Hussein.
Here we go, Doc. So I'm starting with the two or the right side of the side of number 2 or 3. Here we go.
Okay.
So the remaining canine, it does have a pathology related to it,
Okay.
Dr. Resnick.
Yeah. Yeah, and he has a fair amount of bone loss there, kind of all throughout there. The canine, he actually had pretty good bone around it, but okay. And then go to the other.
And
Okay.
that's the left
Okay.
side, sir.
So he doesn't have bone back by the sinuses there. In the anterior, he has a fair amount of resorption here. So Um, the upper is going to be very challenging here. He doesn't have bone in the posterior to get them back where the molars are. So you'd have to either consider doing sinus augmentation or angling the implants. Now with angling the implants, and I think Hussein, you have some planned on the
Yes,
maxilla,
sir.
correct? Um, you're not going to have much bone width around those implants. So his ridge is pretty thin all throughout, especially in the anterior there. So he's lost height and width kind of throughout the entire pre-maxilla here. So do you want to just go through the cross section here just so we could see? So um, Dr. Hussein planned this for a traditional all-on-X with the angled implants here. So this is one of the angled ones in the posterior, which is a 4-3, just anterior to the sinus there, engaging the cortical bone
Then you've
with
got
it here.
implant number 7, Dr. Resnick, a 4-3 by 10 over here, sir. And then we got number 8, a 4-3 by 8, Dr. Resnick. Next is number 10, a 4-3 by 10 over here, sir. And last is number 13. One thing worth mentioning, Dr. Resnick, is that I did not have any restorative reference or like prosthetic reference to Planet in a top to bottom approach with this case, sir.
Yes. So, um, what's difficult with what we have here, Doc, is one, we have very limited bone. We have some pathology around pretty much the area that has the best bone, which is that canine, a pretty significant periapical radiolucency. And then lastly, we don't have any reference to where the teeth need to be. So being that his existing partial that he's in right now has the teeth worn down, they're not in the correct restorative aspect in terms of aesthetics, phonetics, function. So if we were to use his partial, we'd be planting the implants at the incorrect position. So to take a step back, the first step in this case is going to be to do a wax up, or make him a new acrylic flipper or printed flipper with teeth at the correct anatomical location. So you would make a new denture based on where the teeth need to be. So reestablish the incisal edge position, the vertical dimension, and then we take the dual scan CBCT. So you'd use the patient's prosthesis and take a CBCT of that, as well as them wearing the CBCT. That way we can see where the teeth need to be in relation to the implant here. Because based on the way Dr. Hussein placed these implants, he did place them where there's bone surrounding them. But with the amount of bone resorption this patient's had, these implants are going to be placed very lingual here, especially this anterior one here. It's going to be very much towards the palate there. So kind of the a starting point with this case is going to be to make them a interim prosthesis. If you wanted, you could take out the remaining teeth and just make them an interim denture. That's probably going to be a good starting point to kind of get rid of the pathology there. But we need to start by reestablishing the patient's occlusal plane, incisal edge, and then work backwards from that. But even with that, it's going to be very difficult to get implants in the kind of ideal location here with his limited bone quality. He may be somebody that would be a candidate for zygomas, or sinus augmentation, but we'd have to get the dual scan there first.
I see. I was able to get an exocad, like a virtual smile design,
Okay.
from my lab. If that smile design is pretty accurate and is usable, would I still need to have a interim prostheses made?
No, no. If you're able to do if the exocad is accurate, that would help. Now, what's difficult with the exocad is you're just looking at it digitally there, correct? You're not, are you printing a provisional with that and trying it in?
Right now it was just at the very beginning
Just
process,
okay,
so it's
yeah.
just, yeah.
So what they can do is you can print a smile transition off that, so you wouldn't need to make them. So to go through a case like this where you're putting all this time, the patient's putting all the money in, what you don't want to do is end up with the implants in the wrong spot. So
Mhm.
starting with the digital smile design is great. And then you're able to kind of convert that to a chair side smile design. So have them print in Essex or a kind of a transitional smile where you're able to try it in and just verify that you have the vertical correct, the occlusion, incisal edge position, and then plan it based on that. So yes, you can use that, but I would still verify it chair side prior to putting the implants in digitally and in the mouth.
Okay. In this particular case, if I were to do bilateral lateral sinus lifts, would I still need to do an anterior ridge augmentation as well?
Yet, go through the cross section up, start at the canine. So just go through the three there.
You got it, Doc. Here we go. So I'm starting where the canine is,
I
and
think the canine, you're okay. No, yeah, you're gonna have no bone at the canine site there. Um, so it's gonna be very difficult to gain with. So go back here, Hussein. So go back a little further there. So right there, right here. So where he has this implant placed here, he has it where you wouldn't really need to do augmentation. You're doing plasty to the level of it. Um, so depending on where the incisal edge is on your digital smile design is going to dictate whether you need ridge augmentation or you'll need plasty here. So from looking at this, it's going to be difficult to gain width in that. That's not the best anatomy for a ridge augmentation, but you don't need that much width in this segment. You need a little more in the other cross sections there, but the starting point with this is going to be to determine the incisal edge position, because if you need alveoplasty, you're not going to need ridge augmentation. You'll do plasty to the level of the implant there. So if you are doing the sinus lifts, if you're going to do the bilateral sinus lifts, I would do some augmentation in the anterior, specifically that canine site where the pathology is, to at least try to get that, because that's going to be one of our key implant positions. So yes and no. So if you are going to do it a delayed approach where we're going to graft the bone, which I think would probably be the most predictable in this patient's case, I would definitely do some ridge augmentation in the front, give them that interim denture, and then come back in 4 or 6 months and take a dual scan.
Okay. All right. Thank you.
Okay. And then I think we're doing the bottom as well.
That's
Yes,
correct.
sir.
Okay. Okay.
So for the mandibular arch, Dr. Resnick, I plan my implants intraforaminally, sir, tilting the two most distal ones with the help of 30 degrees MUA, and I'm loading the treatment plan right now.
Okay. Perfect. And he is a partial on the bottom as well here.
Yes, he does.
Okay. So it's going to be the same in terms of the restorative, where we kind of need to reestablish it. Now, with the mandibular anterior here, you're going to have to do plasty to get the necessary width. So we're going to gain a pretty significant amount of restorative space just from doing that. But still, based on your exocad plan, we'll just make sure that we have them in the correct position with that. So it'll be similar in terms of that. Now, the patient's bone, let's go through the cross section here, Hussein.
Here we go, sir. So above the mandibular canal, Dr. Resnick, like there is no vertical height of bone above the mandibular canal.
Okay.
Starting at the E position, sir, I was able to plan a 3.5 by 11.5 millimeter long implant, but the lingual concavity over here is so far accentuated that my implant is just sparing the lingual concavity over
Okay.
here. And
So we
this
have about
key,
a millimeter there. Yeah. So you might have to cheat a little buckle there.
right now, sir, it's 0.5 millimeter to the
Okay.
facial
So
aspect.
that's cutting it pretty close there. Okay.
That's the first one. That's the E position, Doc. Then we've got number 22 side, which is a 3.5 by 11.5 millimeter long implant. With this one, we do have adequate bone coverage to the facial and to the lingual aspect, Dr. Resnick. Next one, sir, is number 25, the C position. For the C position, 3.5 by 11.5, abundant amount of bone to the facial and to the lingual. 27 is our next one, a 3.5 by 11.5 Holland tapered implant. Good bone coverage all around, Dr. Resnick. And last but not least is implement number 29, which is a 3.5 by 11.5 using a 30 degrees MUA on top of that fixture. And I'm clear away from the mental framing and the anterior loop anatomy, sir.
Perfect. So they all look great. The E position is going to be the most difficult with that lingual concavity. So that's just going to take some modification from Dr. Hussein there. But the bottom looks a lot more favorable than the maxilla for the patient. So I think 5 implants down there will work out well for you. It's just playing around with this E position just to avoid that lingual concavity, which it may be where you even have to place that one straight there. Hussein, just to avoid it there, which you can play around with that there. But
You got it,
the
Doc.
patient does have better bone there on the bottom there. So I think 5 implants and an all NX down there looks more favorable there, Doc.
Okay, great. Thank you for that.
Yes.
But will we
Okay.
get a copy of the scans as well?
You could send it to them, Hussein?
Oh, absolutely,
Yes.
Doc. I'll
Yes.
definitely make
Yeah.
sure to share it.
Thank you, Hussein.
Pleasure, Doc.
Okay, Doc.
So
Let's
go ahead,
next one
sir.
there.
Sorry.
Yeah.
Dr.
Next one.
Kwong is our next one, and there is no relevant medical history for the patient of Dr. Kwong, but one thing worth mentioning, Dr. Resnick, is that Dr. Kwong is planning on adding 2 implants, being the first implant number 2 at an immediate implant placement site, and the second one is at number 4, which is a delayed implant placement, sir. Dr. Kwong, are you on the line with us?
Yes.
Perfect.
So yeah, she's a 46-year-old lady. Medical history, just a history of depression, but she has an adverse reaction towards dexamethasone. She will get the swelling. Basically, I extracted the number 4 in October last year and grafted. She has fracture. The
the implant on number 3 is because she has fractured her tooth 3 years ago. So I placed that implant as well. And then now, October last year, she fractured the number 4. Yeah.
Okay.
So the number 2, there is showing there's a fracture line on her tooth. So she's debating whether she would do an implant or not, but she's not so fond of doing sinus augmentation,
Okay.
as far as I know. Um,
Okay.
yeah.
Okay. So, to start off, she's fractured 2 teeth in the upper right, or 3 teeth now in the upper right
Mm,
segment there. So she has significant parafunction there. So that's something to take into consideration prosthetically, which we'll touch on here. In terms of doing an immediate implant at number 2, I would highly advise against that. That's going to be a very challenging immediate implant there. I think
mhm.
taking it out, grafting it, if I recall, I was saying she's going to have about 8 millimeters of bone right now, right?
Yes, sir.
So,
Approximately.
um, if you're able to maintain the majority of the bone in there, you'll have about 8 millimeters. So you'll be able to do an implant via either an SA1 or SA2. So she won't need a full lateral wall. It will be a little bump if she does want to replace that option or replace that tooth in the future there. So I would definitely do that delayed where you take it out, socket grafted, and in about 4 months, come back and we'll take a new CBCT and plan that with
Mhm.
that there. Now, in terms of number 4 there, Hussein, let's go to that because that's been since October, so that's healed.
The one thing worth mentioning, Dr. Resnick, at the side of number 4, sir, is that there is a demarcation line where I've got my cursor right now with the
Okay.
bone graft, and I'll leave it to you, sir.
Yeah, so that's more than likely just a little soft tissue that was at the very apex of the socket there. So what you'll find there is it's going to be kind of like an air pocket when you're trying to do your drilling and placing the implant there. So we're going to have a little poor primary stability with it there. So when you're placing this implant, definitely under prep it there. And then if you do have poor primary stability with your implant, I would not place the implant. I would go in there and kind of really degranulate that out. You can even use a round burr to kind of remove all that soft tissue and regraft it there. So, and it's mostly going to be at the apex there, that soft tissue there. So, other than that, you have good bone width and height for an implant there. I think you have a 4.3 by 10. It's
That's an
just at
affirmative,
the
doc.
yeah, it's just at the apex there. You're going to have a little difficulty with that soft tissue down there. So you will be able to get rid of the majority of it with a burr there. It's just not going to be the best bone quality there. So under prep it by 1 or 2 drills with placing that.
Would I be, let's say if I do prep it to the pilot drill like 2.5, and then if I use the site dilator to expand it, uh, and then prep it final with the 3.8 millimeter, then and put in the 4.3, that would that
You
work?
use an osteotome, you said?
Yes, yes.
Yes, yeah, an
Okay.
osteotome would work great on this case. Yes. Yeah, so I would use
Okay.
the osteotome and go to like the 3.8, 3.7, and then place the 4.3 because the implant will also osteodensify the bone laterally there. So yeah, I think that's a great case.
Okay. And
And
what if I am not able to remove that soft tissue? Would that affect the osteo
yeah.
integration?
So what I would do is when you're prepping the osteotomy there, go in there and curette the apex and make sure you don't have any soft tissue there. You should be able to remove it with your surgical drill. So as you're drilling, you will generally be able to remove some of it there. It's just you're
Mm.
not going to have the best bone quality down there. So just when you're going down there, just sound the walls to make sure you have solid bone surrounding the implant there.
So the way to feel it, you would use the curette, the smallest curette
Correct.
to
Yes,
feel
the
it?
smallest curette. Yes.
Okay.
Similar to the way when you're doing it when you're extracting the tooth and you're going to curette the wall to remove the soft tissue, just go down there and make sure you don't have any soft tissue still underlying down there.
Okay. All right. Great. Thank you
Now,
very much,
now in
Doctor.
terms of prosthetics for this case, since they've fractured the teeth, what I would recommend is let's say you do place an implant at number 2, I would splint 2, 3, and 4 together just to give you the best biomechanical um, advantage up there, being that she's fractured all 3 of those teeth there. So you kind of want to
Mm,
over-engineer these cases. So that's just one thing
okay.
to consider about the prosthetic.
Okay. And the choice of material for the crown, zirconia should be okay, or does it
Correct.
matter?
Yes, zirconia. Yep,
And even if it's splinted, I can still use zirconia?
correct. Correct.
Okay.
Yes.
All right.
Yep. Okay.
Great.
Perfect.
Thank you very
Okay, let's
much,
go.
Doctor.
Yes.
Yeah. Thank you.
Next one here, Dr. Hussein. I think we got 4 more
Dr.
to bust
Gandorpe.
through here. Okay.
Yes, sir. So we've got 2 cases for Dr. Gandorpe. I'm going to start with the first one. Doc, would you mind please unmuting yourself and presenting your case, Dr. Resnik?
Yes, I'm right here. I'm not sure which case you had first. I have Miss
So
Lucy.
I think that's Lucy, Doc. That's the first one, the maxillary and the mandibular arch case.
Yes. She's a 54-year-old female. Medical history, she has arthritis, but not on any treatment or medication. She has a history of bruising easily, but no particular diagnosis. Not on any current medications. And she's interested in getting implants in the site of 14 and 30.
Okay. Perfect. And
And
she already had the teeth extracted?
Yes.
Okay, perfect.
so here you go, Dr. Resnick. That's the panoramic image, sir. And I could jump right away into the cross-sectional and take a measurement for you, Doc. And right now, the amount of bone we've got, or the native bone we've got over here, sir, from the sinus to the crest of the ridge is approximately 6 millimeters, Dr. Resnick.
Perfect. So the first thing Dr. Hussein's going to do is measure the bone from the crest of the ridge to the floor of the sinus there. So that's going to
Mm-hmm.
determine how much bone we have, which is going to dictate um, what our implant options are. Have you taken module 3 yet, Doc?
Yes, I have.
Okay, perfect. So you've gone through the different classification there. So with
Yeah.
6 millimeters there, what are our treatment options there?
I think a lateral window and sinus lift.
So with 6 millimeters, if we look at our shortest implant that we're going to place, it's going to be 8 millimeters there.
Mm-hmm.
So now he has 6 millimeters from the mid there. If we go to the side, we're probably going to have a little less there. So it's
Mm-hmm.
probably going to be an SA3.
Mm-hmm.
Now with this, you have a 5x8 there, Dr.
Yes,
Hussein, right?
sir.
Okay.
Five
So
by
if
8.
we look at the cross section there, we have good width. On the buccal and lingual there. And then if we look at the apex of that implant, we're protruding the sinus about 2 millimeters.
And we're exactly 2.4
Okay,
millimeters, Dr.
so a
Resnick.
little over 2 millimeters there. So that's going to be an SA3 uh, implant placement there. So an
Okay.
SA3 is when we're protruding into the sinus greater than 2 millimeters. Now for an SA3, that's where we're placing the implant and doing sinus augmentation. For this case, you can either do it crestally or laterally. This
Mm.
case is going to be a good one to do crestally. So you're not going to have to do a lateral wall in this case.
Okay.
I would do it via osteotomes where you're going to prep just short there, and then you'll bump
Okay.
that membrane up, put a little bone graft in there to
Okay.
consolidate around it there. But what's going to be difficult with the lateral wall in this case is the patient has a
Mm-hmm.
very thick lateral wall, and then it's
Mm-hmm.
also a single tooth lateral wall. So you have teeth on both sides, which is going to
Mm-hmm.
be very, very difficult because you have to make a very small window. Now, if this
Okay.
patient had significant parafunction, they didn't have a tooth distal to it, then we might be looking at doing a lateral wall with it. But for this one, a crestal SA3 implant placement is going to work out well.
Perfect. Thanks, Doc.
Okay, now let's go to the bottom right here.
Right away, sir. So at the bottom, Dr. Isaac, we've got a single implant at the side of number 30, sir. And I'm loading the treatment plan right now for us.
Hello?
Yeah, we're here,
Yeah,
Doc.
yes, yeah, he's going to the bottom now for that
Sure.
one.
So it was for tooth number 30.
Okay.
Mm-hmm.
And have they been missing 30 for a while?
Yes, she has.
Okay.
And she's not sure
So,
how many years she's been missing. She's a new patient to my
Okay.
practice, but it's
o-
been missing for a while.
Okay. So let's just start at this view right here, Hussein.
Mm-hmm.
So what we can appreciate from this view here is go to the neighboring CJ there and draw a line there, Hussein. So you can see all the bone that she's lost at this site number 30 there with the height
Mm-hmm.
wise there. So she's lost probably about 4 millimeters of bone height wise there. Now
Mm-hmm.
to graph that, it's going to be rather difficult to try to reapproximate that bone to the level there. So let's see kind of what we have left there,
Mm-hmm.
Hussein. And we'll go
Here
to the
we go.
cross section.
So the cross section, Dr. Resnick, we've got right now, sir, approximately around 9 millimeters, maybe a little bit less yet, 9 millimeters over here of the crest of the ridge. So what I did, Dr. Resnick, is that I added a single implant over here, sir, a 5.0 by 8 millimeter long implant, doc.
Okay.
Mm-hmm.
So he's able to get a 5 by 8 in there that's going to be away from the nerve that will give you at least 2 millimeters of space. It is going to be a little thin on the buckle there, so you would need to graft the buckle crest at the time
Mm-hmm.
of placement there. Now, um, if we take a step back here and look at the can you go to the pan view of this?
By the way, doc.
Okay. So are you able to, okay, perfect there. So we could see kind of the bone loss there. So what we're gonna have here is a poor crown to implant ratio. So we're gonna
Mm-hmm.
have more force there on the crest of that implant. And then the other thing to note here is it is a pretty wide space. I think it was what, 14 and a half
Yes,
you're
sir.
saying? So with a 5 by 8, that's a shorter implant there at the molar site, especially when we have a poor crown to implant ratio. But we also have are going to have a pretty significant mesial and distal cantilever here. So if
Mm-hmm.
it's 14 millimeters and we have 5 millimeters, we're going to have about, what is that? Almost 5 millimeters of cantilever on both sides there. So um, if we're going to go ahead and plan for a single implant down here, what I would do is try to bulk out the bicuspid. So you can crown the
Okay.
bicuspid and maybe bulk it out a millimeter or two, which is going to
Okay.
decrease the width there because this is going to be a big food trap with the 5 by 8 millimeter implant there. So by crowning that bicuspid in the front, we're going to
Mm-hmm.
decrease kind of the cantilever on both sides there. So
Okay.
that would be something to consider for um, this case. But you do have enough bone to get a single implant there. Just go through with the patient, bulking out the distal of that bicuspid
Okay.
with it there.
Got it. Thanks, Doc.
Okay, perfect. Okay, let's go to the next one here.
One more case for you, doc, and that's going to be your next patient. Here we go.
Uh, yep. This is
Single, go
uh-huh.
ahead, doc. I'm sorry. No, no, please go ahead.
It's a Benjamin for a single implant on tooth number 12.
Okay,
Mhm. As far as medical history, he has a history of high blood pressure. He's taking medications. He's HIV positive and he is taking medications. And he also has a history of acid reflux. He does
okay,
have an implant in the upper anterior already. And
okay,
he was missing a tooth on lower anterior, but there wasn't enough bone to place an implant. So he went with a bridge on the lower
okay,
anterior.
okay. And is he already missing number 12 here? You've already
Yes.
taken it out? Okay,
He,
perfect. Or
extracted
somebody,
prior to being my
okay,
patient. Yeah.
perfect.
Mhm.
Okay, let's go through the cross section here, saying so we should have enough bone. The sinus shouldn't be in the way here. Okay,
I did add a 3.5 by 11.5 millimeter long
awesome.
implant over here, Dr. Resnick, where we've got good bone coverage to the facial, especially at the coronal to the middle third, a little bit thinner at the apical third, but we're well covered with cortical bone over here. As I rotate around this implant, Dr. Resnick, we're 1.5 millimeters away from the lamina dura of the adjacent teeth, perfectly clear away from the anterior wall of the maxillary sinus over here. And what's your thoughts, Doc?
That looks perfect. This case couldn't be more of a home run, doc. So get this patient
Okay.
scheduled tomorrow morning and yeah, this one's perfect. Have you placed a lot of implants?
About 20, 25. Yeah.
Okay, have you done them guided, freehand?
Always guide.
Always guided. Okay, you like the
Yeah.
guided?
I mean, it makes it easy
Yeah.
so far.
Th
Yeah.
this one guided, perfect. They have great bone. This one's a slam dunk here. Now the bone does look a little um it, like it'll be a little softer bone here, so you may want to under
Mhm.
prep it one drill there.
Okay.
Feel the bone as you're drilling and kind of make the decision chair side there, but I would probably under prep it one burr and you should be
Okay.
perfect. This is a slam dunk.
Okay.
Great case.
And any considerations regarding his medical history? Because I usually do put them on pre-op antibiotics, 3 days
Yes.
of steroids. Anything else I should be doing?
So the HIV, we're going to be worried about kind of them healing and the infection there, but the biggest
Mm-hmm.
concern on this patient is the hypertension. I believe they're on
Okay.
three different ones. They're on a beta
Yes.
blocker, ACE inhibitor, and a calcium channel blocker.
Can.
So whenever you're on three
Mm-hmm.
hypertensive drugs,
Mm-hmm.
you're at a pretty high cardiovascular risk. So
Okay.
what they'll do is they'll start by putting you on one. That doesn't work. They add a second one. That doesn't work. They add a third one. So
Okay.
that's going to be the biggest challenge for this. Now, the good news is this is a very simple procedure. I mean, start to finish, especially if you're doing it guided, it should be about 5, 10 minutes with,
Mm-hmm.
maybe a carp and a half of anesthesia, but
Mm-hmm.
definitely get a medical consult on this patient. So get a
Okay.
medical consult, antibiotics beforehand and after, and
Okay.
slam dunk for you there.
Okay. Perfect. Thank you so much, Doc.
Yes.
Mm-hmm.
Okay, Doc.
Per-
Let's go to the last
Perfect.
two here.
Dr. Gupta, Dr. Mahima Gupta. Dr. Gupta, are you on the line?
Y- Yes, I'm here.
Perfect.
Okay,
Welcome
Doc,
back.
how are you?
Hi, I'm doing great. How are you doing, Doc?
Good, good, thanks. So let's take a look here.
So first case for yours, Dr. Gupta, it's Mike, and you've left a note that you're planning on doing implants at 19, 21, 22, 25. Is the full arch case, Dr. Gupta?
Yes, it's a full arch Olonex case. My biggest concern in the case was the positioning of implant at 19 and 30 degree. So my confusion was because Dr. Resnik teaches that you are supposed to put the implant in between the foramens. But looks like I think I do have a space on 19 and 30. So my biggest question is, should I place the implant at 19 and 30 or should I still stay in between the foramen?
So you're taking out all of the teeth here, correct?
That's correct.
Okay. And you're able to get implants interforaminally. You're asking, should you put one at 19 and number 30, correct?
Yes, yes,
Okay.
that's my biggest question.
Okay. So let's go through your plan here, Hussein, and then we'll
So I'm going to scroll really quick, Dr. Resnick, for you, sir, through the remaining dentition. I'm going to
okay.
start with number 19, and I'm going to scroll anteriorly. Here we go. That's number 21, 2, 3, 24.
These teeth aren't mobile, are they, Doc? Are they coming out for perio or
Yes, they are mobile. They are coming
they're
out for the
mobile?
perio reason.
Okay.
Perfect.
Okay. Perfect. So 19 looked like there was a pretty good lingual undercut there.
Mm-hmm.
So it's going to be difficult to get an implant there. Definitely not immediately. I mean, that would be one where you'd have to come back delayed
Okay.
at the 19 position. So 30, you didn't have the lingual undercut there. So in terms of getting an implant there, you should be fine. But we have to kind of determine the anterior implants first. So let's look at the plan here, Hussein.
So I'm going to switch on my implants, but I planned it a little bit differently, Dr.
I
Resnick. I
see.
planned them, yeah, as for a bridge work, so I'm going to start moving things a little
Okay.
bit anteriorly.
Well, so just plan the A and just plan A, C, and E.
Yes, sir. So here's the E position, Dr. Resnick. The size I've got right now is a 4.3 by 11.5 millimeter long implant, sir. And I might be a little bit too close to where the mental foramen is, so I'm tilting it just a
Yeah.
tad. I could use a 17 degrees MUA to correct that. But right now with that position, Dr. Resnick, and if we're using a straight or like an angled MUA, we're going to have approximately 17 millimeters off restored space
Okay.
of that implant, sir.
So yeah, so we'll be fine there. So just for time's sake, Hussein, you have enough restorative space. We'll have enough bone in the anterior there. So Doc, you can get 5 millimeters in between the foramina there. In terms
Mm-hmm.
of getting implants posterior to the foramina, we're just
Mm-hmm.
gonna have to determine the prosthetic. Because if you want to go behind the foramina bilaterally, you're gonna have to break up the prosthetic. So if you, let's say you get an implant at 19 and 30, you're going to need probably 4 implants in the anterior, and then you're going to have to split it 3 and 3 or go 4 and 3 um, with that. So we're not going to connect 19 all the way to 30 there for the mandibular flexure. So the benefit of getting the posterior implants would be you're going to be able to get the patient more teeth in, limit the cantilever with it there. So you're going to have better AP spread. However, you're going to have to break up the prosthesis for the mandibular flexure.
Okay. So can I break the prosthesis? Do you suggest to break the prosthesis like anterior? How would you suggest to
Yeah,
break the
I
prosthesis?
don't do it at the midline because that's the aesthetic. So generally,
Yes.
I'll try to break it on the side there. So in between the canine and bicuspid is usually a pretty good spot.
Uh-huh.
So, let's say you get an implant at 19, 21, 22, then break it anterior to 22, and then,
So
connect those three
basically,
inputs.
almost like an anterior bridge and two right and left sectional bridges.
Correct. Yes.
Okay.
Yes. Um, but they have enough bone there. So that's the only thing is if you're going to consider going posterior, you have to break the prosthetic up into at least two segments.
So what is the best approach in this case? Like if I want to do you think like, just to make my life easy in future, I'm trying to understand more treatment planning aspect in this one. So it's a good idea to just stay in between the foramen and give the cantilever 19 or rather like the way you said, three sectional bridges.
Well, 19, you can't put an immediate implant in. So that's going to be one
Okay.
where you're going to have to take it out and graft it there.
Okay.
So, um, the easiest option is to just put 5 implants interforaminally there. They would
Uh-huh.
angle them so you're going to get better AP spread, and then you
Uh-huh.
can cantilever a molar off both of them, and the patient would have more than enough teeth to chew.
Got it.
And then
Okay.
in the future, if you had to go back, you can always put implants in the posterior. Just plan them accordingly where you can break up the prosthesis.
Okay. So anytime if I'm placing implant outside the foramen, like posterior to foramen, I have to make the sectional bridges.
Correct. Now, if you were only to place it on one side, you wouldn't have to. So let's say since 19, you can't put an implant, you can just put an implant on the right side behind the foramina and connect everything because you're not going to be on the foramen on both sides.
Okay.
So that would be another option for you where you would just put one at, let's say, number 30, because you have the bone there, and that would get the patient a little more teeth to chew on that side.
I think the tooth patient has is 18. Can we place the implant more anterior to 18? Around this
It
point?
looked a little thin there, but
Here.
Here, here we go. Let's give a 4.3 by 8 millimeter an implant shot, and here we go. Yep. So somewhere over here, that's where
So
you
what's your
you
opinion on this implant, doc? The
yes,
same thing.
you'd be fine there. Yes.
So I can place it, but I have to do the sectional.
Correct. Because
So
you're
it's
still
going to be,
behind the
doc,
frame.
sectional FP3 on the posterior?
Yes.
Okay.
Yes.
Got it.
Yep.
Okay. Thank you so much. Yeah, that was
Yes.
my biggest question.
Perfect. Okay.
So we've got a maxillary arch for you as well, Dr. Gupta, for this patient. I'm sorry about this. So my software crashed. Sorry, it's a technical error. I'll reboot it right now.
Okay. And then on the top here, Doc, is it the same thing all on X?
Yes.
Okay. Were you opening it? You say?
Yes, sir.
Oh, there. Okay.
I'm opening it right now, but it's taking its sweet time. I do apologize about that, Dr. Resnik. But here we go, maxillary project. So, Dr. Gupta, I planned for like 2 implants for the maxillary arch. I do apologize about that, but I could fix that for you right away.
Just go through the cross section, Hussein, and then we'll
You
see.
got it, Doc.
Yeah.
Here we go, Dr. Resnik. So I'm going to start with this implants. I'm sorry, tooth site number 3, sir.
Yeah, just go through the side.
And here we go.
So the bone looks pretty good around these teeth, Doc. What's the reason for taking out the upper here?
Dr. Gupta, I think Dr. Resnik was asking you,
Yeah.
why are we extracting the maxillary teeth, Doc?
You're taking all these out?
No, we were not planning. The patient actually, we are not planning to do the upper one at this point. Patient is still thinking.
Okay.
It's mainly, I didn't plan too much on the upper one right now yet. My mainly question was for the bottom one. Like, how should I
Okay.
treatment
Okay.
plan?
Okay. Okay. Then let's just go to the next case, Dr.
Yes.
Hussein.
You got
Yep.
you got it, sir. Perfect. So, last case.
And the last one I think is an all on X.
Here,
Is this an all on X, doc?
You're talking about my case? I think there
Yes.
was one more. Yeah, no, it's not all on X. It's I have only one question in the whole case. So this was my patient, and we were planning to extract lower anterior teeth because they were not in good position and completely perio-compromised. And we planned the 3 implants from 22 to 20, actually 20.
six.
Yes, the anterior 3 implants we planned it. My biggest question was when I was discussing the case that we should be placing the implant in the embrasure area. I wanted to understand that particular part.
Okay. So you're taking out what teeth are you taking out?
So I'm taking out, I'll have to remember, I'm taking out from canine to this side 25, not the
Okay.
canine, like 26, not the canine on the other side, 27.
Okay. Okay. So you're taking out, okay. So first off, the teeth here, I don't think are in the correct position. So if you go through
No.
they're way too splayed out forward there. So you can't really use where these teeth are for planning purposes because they're so far out of where they need to be.
Actually,
So
I submitted another thing. I think it didn't come there.
okay.
So what I did, I extracted those anterior teeth because it was so difficult to plan
Okay.
implant.
You did take them out. Okay, perfect.
So I already extracted the teeth and I made the partial denture for patient. And I
Okay,
put the radiographic marker on the partial denture
perfect.
and submitted another CBCT.
Okay, so we just don't have that, so we'll take a look at that, and what they'll do is they'll send it over to myself or my father, and then we'll look at it there. To answer your question, so you have a partial made for the patient that has 26 to 22, correct? Or 22
Yes.
to, yeah. So you want one implant at the canine site. So if we look at our most important site, the canine is going to be the most important site there. So
Mhm.
you're going to put one implant at 22.
Okay.
And then in terms of 23 to 26, you'll
Mm-hmm.
put two implants in the embrasures there. So you'll put it in between 23 and 24 and then 25 and 26 there. The reason we do that is because generally it's going to be very difficult to space them with the canine. So that'll give you a little more space in between there. And then you would just do a 4-unit bridge there.
So regarding 22, implant is going to be exactly as if I'm replacing a single tooth.
Correct.
That is not
Correct.
going to be in the embrasure of 22
No.
and 23, right?
No. I would put it at 22 there because you need the implant right where the force is for the lateral excursions.
And anteriorly, we are just doing it because it's so difficult to place implant next to each other because the teeth are too small.
Correct. And then you'll also limit the amount of space in between them.
Okay, for the better spread of
Correct.
the.
Correct.
I
Yes.
understood. That was the biggest concept I was
Yeah.
not able to understand.
Yeah.
Okay,
But no,
that's it.
good thing that you took, because we were looking through this and I don't know how you can use these teeth to plan. They're so far out of whack.
No,
So
I extracted. I couldn't plan it.
yeah.
It
Okay.
didn't look nice, so
Perfect.
I did that.
Yes. So submit that other case and they'll send it over to us. Okay.
Okay.
Perfect.
Okay. Thank you so
Thank you,
much,
Dr.
doctor.
Gupta.
Okay. Good. Okay. Any other
Great.
cases, Dr. Hussain?
I guess we're done for the day, sir.
Okay, perfect. Well, thank you for the time. Thank you guys all for coming on, and then we will see you back in a couple weeks. Just get your scans over to Dr. Hussain at ITX there.
Thank you, Dr. Resnik. Thank
Okay,
you,
good
everyone.
night.
Good night,
Good
sir.
night. Thank you so much.
The
Thank you.
case, so you can send them the information and the